I'm here with Dr. Chris Arden, who is a GP with a special interest in cardiology, who is based at Southampton. Chris, thank you very much for joining me for this educational program today. I would like you to explain to us what is your daily activity. What, as a GP with a special interest in cardiology, what is the focus of your activity?
Thanks very much indeed for inviting me today. And I mean, first and foremost, I'm a GP, doing general practice 3 days a week. A day and a half a week, I also have an interest in cardiovascular disease and run a community cardiology clinic in Southampton where we see patients with suspected heart failure and atrial fibrillation. Obviously, a lot of those patients do have a background of ischemic heart disease, so a lot of our work does involve managing and advising GPs about managing patients with ischemic heart disease and stable angina.
Right. I think you would agree with me that we are facing an important challenge in terms of managing chronic stable angina, because the cases are frequent, the incidence, I think we see approximately 50,000 men developing coronary artery disease every year, and a similar number of women being diagnosed with coronary artery disease every year. In your view, are we ready to face the challenge? In primary care?
Yeah, no, very, very good question. And I think in some ways I don't think we recognise how big the challenge is. I think what we've seen over the last 10, 15 years is huge advances and developments in terms of management of cardiovascular disease, particularly in the acute setting. So a lot more patients now are doing very well and being managed very well acutely, and obviously coming out with long-term coronary artery disease and stable angina. And I don't think we recognise, just in terms of the sheer numbers of patients that are out there with ischemic heart disease and angina, which by and large is stable but may well be symptomatic and still having an impact on that patient's quality of life. So our focus has now moved from one of managing prognosis and keeping patients alive to now looking maybe at the quality of life of those patients in the longer term, and particularly around managing their symptoms. Right. And I think obviously that responsibility lies very, very much in primary care. Indeed. And for us as GPs to make sure that we're aware that may still be an ongoing burden for a lot of patients.
And in terms of recommendations you give to your patients with chronic stable angina, which are the key recommendations you would identify?
And first and foremost, certainly I'd always revisit the lifestyle. So I think we can always take the opportunity of just reinforcing positive lifestyle measures, whether that's around exercise, rehab, obviously smoking, and making sure that secondary prevention is very much in place in terms of ACE inhibitors, antiplatelet agents and statins. Following that, again, we just need to make sure that we're asking the right questions and are vigilant that patients may well still be symptomatic and either not declaring the fact or actually living within themselves in terms of limiting their exercise because they are still getting anginal symptoms. So we need to be vigilant about that and make sure that we're asking the right questions. And if that is the case, making sure that patients have appropriate optimization of their medical therapy on a background of revascularization if that's already taken place. Yeah.
You mentioned pharmacological agents. Some years ago we had only maybe 2 or 3 drugs to treat chronic stable angina: nitrates, beta blockers, calcium channel blockers. Now in the past few years we are seeing quite a number of drugs emerging with very interesting mechanisms of action, and one of those drugs, which is the focus of this educational program, is ranolazine, acting through a mechanism which is blocking the late sodium current within the myocardium. What is the role you actually envisage for Ranexa in the context of managing chronic stable angina?
I think its real advantages are certainly its tolerability. I think it's neutral hemodynamic effect, so minimal effect on heart rate or blood pressure certainly is an important consideration, particularly when a lot of these patients may be more elderly on other medication which may well be affecting their blood pressure, and obviously have other comorbidities which we need to take into account. So that's certainly an important consideration. Relatively few drug-drug interactions again is a favourable consideration as compared to some of the other medication, and again just making sure that it's it sort of works well with other medication that they're taking, and looking at other opportunities maybe of optimizing some of their other medication as well.
In terms of efficacy, I think the evidence in the literature is quite favorable. In your view, you're convinced that?
Very, very much so. And certainly again around sort of, you know, improving quality of life, improving exercise tolerance, reducing frequency and episodes of sort of angina attacks. Certainly the evidence is very convincing. Also around sort of admissions, and from our point of view looking as commissioners in terms of what we can do to help these patients who obviously often are sort of frequent attenders at hospital with chest pain, whether it's sort of in the ED or sort of with admissions as well. Certainly if anything we can do to help reduce that will be beneficial from the local sort of health economy point of view, as obviously as well as the patient themselves. Yeah, absolutely.
The NICE guidelines recommend ranolazine as an add-on therapy. I mean, you combine ranolazine with sort of the conventional calcium channel blockers, beta blockers?
Yes, yeah. I mean, I'd certainly very much favour sort of beta blockers in terms of their additional sort of disease-modifying sort of benefits. So certainly very much using beta blockers first line. I mean, calcium antagonists again probably more symptomatic control rather than sort of disease-modifying control. But yes, no, certainly wouldn't have any reservations about looking to add in ranolazine in those patients who are still symptomatic.
There have been some concerns about QT prolongation and the interaction with drugs, say, for example, antiarrhythmics class 1A and class 3 except amiodarone. What precautions you take in primary care to avoid having that kind of side effects or adverse effects?
Again, I think certainly looking at the individual and looking at their medication, making sure they're not on any other sort of antiarrhythmic therapy that may again be prolonging their sort of QT interval or affecting their sort of repolarization. Looking at their renal function and hepatic function, so making sure that they've got good sort of baseline function. So again, just making sure that you're using it in the right patients. But again, it will be probably the minority. The majority of patients, and certainly looking at the data and the sort of relevance of the QT prolongation, my understanding is that there wasn't any sort of clinical relevance or adverse effects from that. Okay. But again, there may be certain patients who you'd want to work closely, you know, with your sort of consultant hospital colleagues, just to make sure that it is the appropriate therapy for them. But again, we do recognise that you know there are some challenging patient groups with refractory symptoms in whom revascularization isn't sort of considered appropriate. But again, they potentially also have a lot to gain if we can control their symptoms. And again, there's good observational data to show that ranolazine certainly can be very, very effective in that cohort. Right.
And in real life, you would start a patient on 375 milligrams twice daily, for example, and then would you go up? How would you go up?
Yes, I'd certainly be looking to titrate. I mean, forced titrating. Again, we know they get better symptom control at the 750 BD, so I probably would be encouraged, and certainly encourage my colleagues to look to sort of force titrate and optimise sort of dosing, because again, we know that reduces admissions and certainly improves sort of symptom control.
Excellent. Well, I think we have many options now in terms of anti-anginal drugs, and it's a nice problem to have, because it allows us to tackle different pathogenic mechanisms in different patients, and I think we can tailor the treatment in a way that will benefit patients.
Absolutely, yeah.
So it's been a great pleasure, Chris, to have you here with me today. Thank you very much.
Thank you very much indeed. Thank you. Thank you very much. Thank you.